session, I will introduce my colleague, Dr. Hasan Frookh. He's a consultant endocrinologist and diabetes at Salmania Medical Complex. Also, he's my colleague at Arabian Gulf University. He will talk about the unmatched mortality benefits of Forxiga.
يعطيك العافية Dr. Amjad. Thank you very much, Mr. Chairman. And good afternoon, everybody. My name is Dr. Hasan Frookh. I'm going to talk about revolutionizing the management of CKD in type 2 patient who they have mild or even normal deterioration in renal function. And as Dr. Asma, she already mentioned about the SGLT2, so our main talk will be about the SGLT2 inhibitor in these patients, especially if they have a very minimal deterioration in their renal function. So this, I have nothing to disclose. And the main content of my presentation today is to highlight the outline burden of CKD and importance of CKD diagnosis in patients with type 2 diabetes, and then to establish the risk of mortality and rate of mortality and comorbidities in CKD patient with type 2 diabetes. Then to understand the evidence base among using the SGLT2 inhibitor in patients with CKD and type 2 diabetes. Then to implement this evidence into the clinical practice and to see how can we manage these patients with CKD and type 2 and how can we improve their outcome. So to start with, first, as everybody knows that diabetes is the leading etiology of CKD and end-stage kidney disease, and it's estimated about 40% of patients with type 2 diabetes developed CKD in their lifetime. And of course, CKD is a progressive disease, and the risk of end-stage kidney disease and mortality increase by decreasing the estimated GFR. As the GFR is decreased, then the risk of morbidity and comorbidities in these patients increase. As you can see here, when the GFR is below 45, the risk is very high, especially in those patients with older age. And CKD is representing that's considered the second leading cause of death among the world top 10, surpassing the colon, liver, and breast cancer. So it's a devastating disease. So to act early, preventing the progression of CKD in these patients is very important and vital for our patient with type 2 diabetes. So what is the current approach to prioritizing the patient management with type 2 diabetes in individual at risk of CKD progression? So what we have to do to prevent this progression? And to answer these questions, let us take one example, which we can see patients like Sarah in our daily practice. Sarah, she's in early 50s in her age with type 2 diabetes. She's currently receiving losartan metformin. Her blood pressure is more or less in the borderline 140/90 with estimated GFR 74. So many of you and everybody is seeing these patients, these type of patients where the GFR is within this range. And her HbA1c is perfect. So 6.8, we consider that's within a target. And she's a dyslipidemia with the LDL cholesterol 121, HDL is 55, and triglycerides 158. So Sarah, she came today and she's concerning about whether she has a risk of progression to CKD. So what is the clinical goal, our aim to do and to act to prevent Sarah's progression to CKD? Is our aim to just prevent the CKD progression and end up with dialysis or end-stage renal disease, and to prevent the complication which might happen with type 2 diabetic patients, that's cardiovascular disease, heart failure, and ischemic heart disease. And of course, to reduce the hospitalization, and at the end, to improve the quality of life and decrease the comorbidities and mortality in these patients. So to act early and to do all these things and to prevent Sarah from progression. So let us see what's the guideline actually emphasize us. As you know, Dr. Asma Al-Jabri, she mentioned that we need to prioritize our patient. The guideline over the last 5 years being categorized the patients according to their comorbidities, whether they have atherosclerotic cardiovascular disease, heart failure, CKD, or even obesity. And we have to choose the medications which act on each category of these patients. And of course, SGLT2 inhibitor among these medications, which is very importantly, you have to tackle these patients where they need to start SGLT2 inhibitor to act as early as possible. So we don't wait till the CKDs progress, then we add the SGLT2 inhibitor or even the GLP-1. And as you know, there are two medications now, GLP-1 and SGLT2 inhibitor, which consider our prioritizing medications in type 2 diabetic patients. Not only the ADA guideline, but also if we go and see the KDIGO guideline, where with their new recommendation, as we have the old recommendation to use the SGLT2 inhibitor in CKD with type 2 diabetes, to recommend treating patients with type 2 diabetic and CKD, and their estimated GFR more than 20, or to use SGLT2 inhibitor, which take 1A recommendation. But with the new recommendations added to the KDIGO guideline, where they recommend to use SGLT2 inhibitor in patients with estimated GFR more than 20, and if their albuminuria more than 200, or if they have heart failure, irrespective to their albuminuria, regardless whether these patients are type 2 diabetic or not. And if the patient is CKD, irrespective to type 2 diabetes, we suggest to treat the adult patient with estimated GFR more than 20 ml per minute, or albumin creatinuriria less than 200 with an SGLT2 inhibitor. So the guideline emphasizes about using the SGLT2 inhibitor among patients with or without type 2 diabetes with a CKD disease. So what is the mechanism of SGLT2 inhibitor? Dr. Asmashi already mentioned about that one. And as we can see that before we use ACE or ARBs among patients with CKD, as you know that ACE and ARBs, it will act mainly on the efferent vasodilatation, decreasing the intraglomeralular pressure, while the Forxiga or the SGLT2 inhibitor, empagliflozin, will act on afferent vasodilatation, and again, reducing the intraglomerular pressure. So the primary action or mechanism of SGLT2 inhibitor is not depend on the blood glucose lowering effect, but it is only and not limited to type 2 diabetes patients. But as you can see here, it will reduce the intraglomerular pressure, and that's why you can use it and get a benefit for CKD patients. And of course, when you just want to treat patient with type 2 diabetic patient or CKD, you need to order these two tests. That's the estimated GFR, where you need to see the kidney function as well as to see the kidney damage by checking the albuminuria. So you don't depend only on estimated GFR or albuminuria, but we have to combine these together, because at the end we need to implement this into the heat map, where you can see you can categorize your patient whether he has a high risk or not. And as you can see, our patients, she has an estimated GFR 74 ml per minute. That's she belongs into a normal or to mildly decrease in her kidney function. So the cardiac and renal system are linked as together, as we know that we have a cardiac, renal, and also we have like type 2 diabetes patients adding onto these patients, making the CKM or cardio kidney metabolic syndrome, which each organ lead to other. Damage to the heart will lead to the damage to the kidney, and vice versa, damage to the kidney will lead again at the end to damage the heart. So we need to protect the kidney to prevent the cardiac complication, and of course to treat the cardiac patients to prevent the renal complication. So the life expectancy is not a diabetic adult with early stage CKD is 5 to 6 years shorter than those without early stage kidney disease. So being an early stage kidney disease, you will have a shorter life expectancy than normal without kidney disease. So what Forxiga has demonstrated as a cardiorenal benefit across broad spectrum of renal function, we have two main studies. One is the DECLARE-TIMI studies, and the other one is the DAPA-CKD studies. The DECLARE-TIMI studies being mainly conducted on type 2 diabetic patient, while DAPA-CKD is being conducted on both non-diabetic patient as well as type 2 diabetic patients, where you can see here in DECLARE-TIMI studies being mainly involved in those patients would have more or less normal kidney function, estimate about average their estimated GFR were about 85 ml per minute, where DAPA-CKD mainly on those patients with having GFR below 60 and about an average 43 ml per minute. So Sarah, she's having now mildly deteriorating in her renal function, and our aim to treat Sarah is to initiate a cascade of heart and kidney damage to prevent her from further progression to kidney and heart damage. And the CKD and heart failure are the earliest and most common cardiovascular complication in type 2 diabetes, and 40% of patients living with type 2 diabetes will develop CKD or end-stage kidney disease in their lifetime. So our aim to act early with treating Sarah before she's further deteriorate into end-stage kidney disease. So to inflict this on Sarah's case, as we know that Sarah's belong mainly to DECLARE-TIMI studies, 58, that highlight the representative of the general type 2 patients, where you can see in your daily practice where they have mildly deteriorating in their renal function. DECLARE-TIMI is conducted on 17,000 patients. Mainly they are type 2 diabetic patients. And as you can see here, estimated GFR among these patients more or less more than 90 in almost 50% of these patients. And their albuminuria less than 30 in 69% of these patients. So more or less, we are dealing with patients mainly with normal or mildly deteriorate renal function, like what we have here as example, Sarah. And what they found that, or the primary endpoint above this is that to see the primary endpoint to prevent the cardiovascular complication in these patients and to prevent hospitalization and to reduce the major atherosclerotic cardiovascular disease. And the secondary endpoint was to see the decrease or deterioration in renal function among these patients. You can see here the separation between the two lines, placebo versus the SGLT2 dapagliflozin act or almost occur after 2 years from starting the treatment, where clearly demonstrate that decreasing in renal function was much less with starting SGLT2 inhibitor dapagliflozin among these patients, and relative risk reductions about 47% reduce in deterioration and decline in renal function in these patients. So to start with SGLT2 as early as possible in these patients prevent at least 50% of progression into end stage or decrease in kidney function. And what does the dapagliflozin act or do to these patients? Usually, if you can see the albuminuria progressions happen from normal to micro to or macroalbuminuria would be reduced by 21% in these patients. And normal or microalbuminuria to higher grade of microalbuminuria in 27% will be reduced, and normal or microalbuminuria will be reduced to macroalbuminuria by 46% of these patients. So there will be decrease in albuminuria among all these types of patients if they have either normal to micro, or even normal to macroalbuminuria will be much reduced. Not only this effect, but also will be a regression of albuminuria among these patients using the SGLT2 inhibitor dapagliflozin in about 54%. From micro to macro albuminuria will be reduced to normal or even microalbuminuria. So dapagliflozin considered the first SGLT2 inhibitor being used in a CKD patient with or without type 2 diabetes. So not only type 2 diabetes being used to treat with SGLT2 inhibitor, but also non-diabetic patients will get benefit from SGLT2 inhibitor. And this is the landmark of DAPA-CKD studies, the trial which include studying in type 2 diabetic patients as well as non-diabetic patients. 32% of these patients were non-diabetic, and their estimated GFR between 75 to 25 ml per minute, with the albuminuria between 200 to 5,000, and their mean blood pressure were 130 to 78, and 97% of these patients were on maximally tolerated ACE or ARBs. What we can see here that decline in kidney functions occurred in about 39% relative risk reduction and prevent the cardiovascular complication among these patients. So almost after 2 years, there were separation of the line between the placebo and dapagliflozin and reduced about 39% in relative risk reduction in deterioration to kidney function and end-stage kidney disease. What about the albuminuria? Also, it's been clearly shown that DAPA-CKD secondary endpoint also reduced the cardiovascular death and hospitalization for heart failure in 29% in these patients. The albuminuria being clearly demonstrated by decreasing from as early as beginning from 2 to 4 months, where the separation of the two lines with 29% relative risk reduction between the dapagliflozin and placebo in these patients using dapagliflozin. So where there will be a reducing in albuminuria in patients start treating with dapagliflozin as early as possible, like 2 to 4 months. So starting Sarah on these medications before deteriorating into her renal function is a very important, and we have to act as early as possible. So what is the dapagliflozin will add to these patients? That it will add to reduce all-cause mortality for patients with CKD, reducing the cardiovascular death for patients with heart failure, and reduce ejection fraction, and the cardiovascular death across the range of different range of reducing ejection fraction. And this is the outcome, that there will be a reduction in 31% in relative risk reduction in all-cause mortality and 18% relative risk reduction in cardiovascular death among patients with heart failure with reduced ejection fraction, and 14% relative risk reduction in patients with cardiovascular death across different range of ejection fraction. And we have a different type of dapagliflozin. We have dapagliflozin in monotherapies or dapagliflozin in combination therapy. As you can see, it's combined with SGLT with metformin. We have two combination, that's either 1,000 or 500, and we have dapagliflozin 500 and 10 milligram, or we have dapagliflozin 10 milligram. So you can choose according to your patients. And dapagliflozin 10 500 is available, but it's not widely used. And of course, you see that Forxiga 10 milligram, one tablet once daily, and it's been approved to be used with a GFR more than 20 or 25. And if the patient is diabetic, you need to use the dapagliflozin. At least the GFR should be more than 30 to get the benefit of glycemic control. And thank you very much for your attention, ladies and gentlemen.